Should it be, is it okay if it takes 6 days to return a result? For cancer, that might be okay. For acute infections like SARS-CoV-2, that's absolutely not okay if your goal is to limit transmission. And so in any case, I want to talk a little bit about how we explored this and how mathematics was helped us to effectively, drive. Is that not working? There we go. How we use mathematics and simple models in this case to drive a better understanding of sort of defining what a diagnostic tool looks like for pandemic response. So normally, if we're thinking about testing, we think about sensitivity. The FDA thinks about sensitivity. Most physicians think about sensitivity. You don't want to miss a case. You don't want to miss a case. But is that necessarily the case with a pandemic? Is sensitivity the most prioritized aspect of a test, or is it access to a test? A physician is in a pretty favorable position to not have to worry too much about access because they're there with a patient. They know they can order something from the pathology lab. But at a population level, access and speed of results actually become paramount. So we have to think a little bit differently about tools once we know that we're using them for public health use. And so I'm going to show this. Probably most people are well aware of this type of dynamic at this point. But this is an example of a SARS-CoV-2 infection. And I'll use this in a few different parts of this talk. But when somebody gets infected, they have, there's effectively a period of time where nobody's ever going to be detectable as positive. That's when the virus is just ramping up. It's getting to the threshold of detection on a highly sensitive assay. But during that early phase, it starts to grow and then it starts replicating really fast. And then it takes a long time for the RNA to dissipate. But the viral load, actually, after around 5, 6, 7, 8, 9 days, the actual transmissible infectious virus massively subsides. And so this is really important, and we'll get into why, but it's an asymmetric relationship. So you have this like really fast ramp up, exponential growth of the virus, and you can see this is not a linear scale. This is a logarithmic scale, which has massive implications here. We're going from 1,000 viral particles when you're detected to 1.5 days later, you could have 1 trillion viral particles per mil. So the amount of virus that you end up having is exceedingly high for people with very, very fulminant infections. So for those of you who don't think a lot about logarithmic scales or who don't think a lot about viral loads, so viral loads are measured by the cycle threshold value, CT value on a PCR instrument. This is an example. So every time a cycle goes through, it doubles. So if you have some RNA at the base of the reaction, as you cycle through, it's going to amplify double, double, double. And so, so we end up seeing an exponential growth inside a PCR machine. That's referred to as a cycle threshold when it passes the threshold of being detectable. Anyway, the point that I want to show here is that cycle thresholds is usually how we display viral loads. And so if you're looking at a graph like this, and this is kind of like the same graph I showed before, and I said, when are people most infectious? You'd probably say, I don't know, sometime between like day 2 or 3 and day 11. So that's kind of where your eye goes, like on that triangle. And that feels like that's the bulk of the virus. But actually, these two graphs are identical. These are completely identical graphs, just one on a linear scale, one on a logarithmic scale. And what it really exemplifies is that almost all of the viral load you're going to have in your body during the course of an infection happens during a very, very narrow window of time. And if you don't have a test that's going to hit you during that, that's going to be useful during that narrow window of time, you're not going to have a test that's useful for stopping spread. And so that's where a lot of people worry about, well, what about the beginning phase? Like if you're below the limit of detection, well, yeah, that's important, but that might be a very short window of time compared to the really long period of time after you're infectious, that it really doesn't matter anymore. Your viral load, that explosion of virus, the virus replicates so fast that you essentially have to clear it or you go to the hospital. Like the viruses don't play in the linear range. They just like they explode and they get cleared or they don't. And so getting a test that's going to work within that very acute phase of just a few days is absolutely critical when we're thinking of how to use a test for infection transmission mitigation measures. So although most approaches of looking at tests and thinking about tests during the pandemic and before have focused on the analytical sensitivity, is it good at 100 copies per mil or 1,000 copies or 10,000 copies per mil? Actually, time is much more important because the virus getting at 100 copies per mil isn't that important when the virus is going to grow up to 1 trillion copies per mil. That little limit of detection difference is actually insignificant compared to the timing. If you have a test that could take 10 minutes versus 4 days, they're not even near comparable in terms of their effectiveness. And so an example here is if you have an infection like SARS-CoV-2 where your infectiousness period is about 6 days, which is on average about what it is, and your test result takes 2 days to return, then it doesn't really matter how good your test is analytically. You're already down at a maximum, what I call effective sensitivity of 67%. You're already base level, you're missing 2 out of the 6 days by default, just because that's the turnaround time of the test. And so that's actually much more important. None of the rapid tests have a 67. They're all above 67%, but most PCR tests have over a 2-day turnaround time. So timing is really important when we're thinking about public health tools, but it's actually completely absent for the most part from our regulatory considerations and how we traditionally evaluate a test. We don't generally think about time. But if you said to an oncologist, sure, I'll get your result back in 2 years, everyone can intuit that that's not okay. But for some reason, we didn't intuit that like 7 days wasn't okay for SARS-CoV-2 at the beginning of the pandemic. We spent billions and billions and billions of dollars in the United States getting people results back 10 days after they were sick, after they were positive. That meant that we spent billions and billions and billions of dollars doing nothing. Like literally, those are useless tests 10 days later. The best thing that they could have done was for medical purposes to help somebody identify that that is what was wrong with them. But for public health use, which is again why we're doing most of the testing, they were completely useless. But we stuck with it because it was the most sensitive test, but not the most effective. So as a very, very simple example of like how we can start to frame questions around testing practices and what qualities of a test we might want from a pseudo-mathematical perspective here, we can ask the question, well, if you have 100 people normally infect 130 other people, like an R of 1.3, then you might have 600 new infections per day. This is just a toy example. You might have 600 new infections per day a few weeks after that, or 35 days after that. But if you're a public health official and somebody comes to you and says, I have this great tool, and I promise you that for every 100 people that get infected, only 90 infections are going to happen. Most people are going to run for the hills. They're going to say, heck no, I don't want anything to do with that tool, whatever it is you're talking about, because you want me to sign off on allowing 90 new infections for every 100? That sounds awful. That's 9 out of 10 people are going to lead to a new infection. But that's kind of like how doctors would think, or that's not thinking at a population level. If you take a step back and you say, well, wait, what does it actually mean at the population level? Well, what on face value sounds like it would be New York Times embarrassment for some politician to roll out a program where 9 out of 10 people transmit it onto somebody else. The reality is, when we're talking about exponential growth and decay of outbreaks, that's a massive win. If you have 1.3 for every 1 infections become a new infection versus 0.9, well, then your R is below 1. And so in that same time frame, instead of 600 new infections per day, if you build it out to 6 weeks later, you have 40 new infections per day. It's an over a 90% total reduction for a program that at face value sounds pretty darn crappy. But it just takes a little bit of thinking about the mathematical consequences and compounding interest to understand why these things are so valuable. But it was really, really hard for policymakers to justify this without seeing, well, even with seeing mathematical data, they couldn't really wrap their heads around it. But it's why we need to continue pushing for developing the models and the algorithms, really simple ones sometimes, for people to understand who are making decisions about the fate of a pandemic. So here's a different example, why speed matters. So here you have two identical scenarios on the top and the bottom. On the top, you have a 100% sensitive PCR test. On the bottom, you have an 80% sensitive rapid antigen test. If you ask most policymakers or just health officials or people, say you're in charge of running your school or your kid's school, and you have to decide, well, what test do I use? Most people are going to stick with the 100% sensitive PCR test. They're going to say, well, it's 100% sensitive. I can't go wrong. Great. But if you have 5 people walk into this, I'll show it over here. If you have 5 people walk into the school with a 100% sensitive PCR test, then the simple math, and the test takes 2 days to return, then that's 10 person days collectively walking around infectious. So although you end up getting all of those people, you have 100% sensitivity, so you get them all out of circulation and isolated. In the process, they led to a whole slew of additional potential infections that now need to be quarantined, and a whole bunch of new infections. On the other hand, if you have your 80% sensitive test, which was the lower threshold that the FDA was willing, even when not 48-hour turnaround, but 7-day turnaround was the other option. 80% sensitivity, most people are saying, oh, I don't know if I want to do with that. Even 60 or 50 would be better. You have those same 5 people walk in, and immediately, if you were using a rapid test as your screening tool, you'd immediately pull 4 of those people out of circulation. So even in a worst case scenario, you then just have the one person walking around, infecting others for a few days before another rapid test finds them. So even though it's much lower sensitivity, the speed is what made all the difference there. And so you have much, much better outcomes. It's just there's no math there. It's just a very simple model to understand intuitively. Yeah, we don't usually think of it like that. But when you think about person days walking around infectious, all of a sudden speed makes all the difference in the world for a pandemic response. So we can look at some of these questions using mathematical models. So this is for anyone who's familiar with ecological modeling of all different sorts. We use ecological modeling like SEIR models all the time. They're differential equations. There's a whole slew of different approaches that you can take, agent-based models, SIR compartment models with exponential decay parameters, things like that. But in any case, we can look at, these are ways to look at a population transmission model. So you have a pool of susceptible people. Susceptible people can get exposed. And in this case, they get exposed and they're not yet infectious. They can get exposed and they become infectious, or they become detectable. They then become infectious. Then they recover, and then they recover. So that's just one example. We can map these out and create mathematical models underlying sort of dynamic, like population level dynamics. And within these, we can embed things like viral kinetics. So we can take a simple kinetic curve with a lot of variance across individuals, or we can just have averages, plugged in. But we can, every time somebody gets exposed, we can add, we can overlay a viral load kinetics model on top of it. So we can start to actually build up mathematical models of people bumping into each other at different parts of their viral load trajectory. And based on when they bump up against each other mathematically, if you will, stochastically, they will have more or less likelihood of transmitting. So we can just use these tools to effectively develop population models of what an outbreak might do. We can do that. So this is just an example of a number of different viral load trajectories, not all the same. You can add all kinds of stochastic features into them. What's the peak viral load? What's the duration, mRNA positivity, all this stuff. And then you can ask questions. Once you have your population developed, and each time somebody gets exposed, you have your kinetics model within host developed, you can then start playing with that to ask, well, what are different interventions we can look at? And so one of the very basic interventions we looked at was, well, how much does sensitivity, which is what the FDA prioritizes over everything, how much does sensitivity matter compared to time and frequency of the test? And here's about PCR sensitivity, 10 to the third. So you have it could be 100 copies per mil, it could be 1,000 copies per mil. And in general, antigen tests are turning positive around 100,000 copies per mil. So even though those are 100x difference in analytical sensitivity, an important piece here is that the difference in time between a virus when it's growing up inside somebody, the difference in time from when it's at 10 to the third versus 10 to the fifth is a very short amount of time. A few hours to maybe a day for some people. So in general, if you can have a test that's much more available and accessible much faster, but has a higher limit of detection, that higher limit of detection probably is fairly insignificant because the only time it matters is if you happen to test in this one little time frame. So we can take these kinds of ideas and parameterize models around it. We can ask questions like, in the population, if you were to use different testing strategies with different delays of those tests and things like that, well, what would be the what would happen with the outbreak? So this is an example of what happens with R, the effective reproductive number of the outbreak, which kind of defines whether the outbreak is going up or down. Well, it does define that. If we tested everyone daily, we would essentially have no outbreak. The R would be so low if everyone tested themselves daily. Even if some people missed, the chains of transmission would never be able to expand high enough. But we can't really practically do everyone tested themselves daily. Well, what about every 3 days or weekly? Or what about in certain locations like nursing homes? This doesn't have to be across the whole of the US or the whole of Canada. This could just be within nursing homes. The dynamics still are quite similar. And we've done those models. And what's important is once you start getting to testing, regardless of your test sensitivity, it really doesn't matter. The most important thing is the test frequency is really what's driving any changes qualitatively and quantitatively. Once you start getting to 2 weeks or so, then you're really starting to lose the population level benefits of any sort of testing program. And if you're getting a PCR, most people in this world did not get a PCR test more than once a month. Maybe some universities might have. Rapid antigen tests, it's much more feasible, but most PCR testing wasn't happening. The outbreak starts to lead to more infections overall at the end of it. And so the point is, we can develop these models to start building up the evidence base to explain why why what on face value doesn't look so good actually might be quite a lot better. We can look at what happens if you have an outbreak surging northward and you have different testing strategies. So you might have 10% complete failures of the test. People are saying, well, what about some tests don't work? Some people might not want to participate. Well, the good thing is this is all just about cutting transmission chains. So if we can model that out, we can say, well, what is the exponential sort of, what is the benefit of cutting off the whole transmission chain early? Even if not everyone's cutting off their transmission chains, can you get R below 1 at a population level? And it turns out you can. So this is actually an agent-based model that we have here, where we have all different people in a simulated environment running and bouncing into each other, spreading the virus to each other. But if as the virus is going north really fast within the population, if you were to all of a sudden slap on an every 3-day rapid testing program so that 75% of the population was testing themselves every 3 days, you'd be able to really start driving the outbreaks down very, very fast. If you had every 7 days and half of the population didn't want to do it, you'd still have a pretty good outcome. Eventually it would slow down and you'd start driving cases down. You'd start to get R below 1 pretty darn quick. And that's the key here. We started doing this modeling when there were no other options for COVID. There was no treatment, there was no vaccine. But we did have tests, and we could have used tests much more effectively at a time when we had 4,000 or 5,000 people a day dying in the United States every single day. If we look at this, the only point for anyone who's a student here, or anyone really, the only thing I want to show with this is we have really simple compartment models, which are just like a few lines of code essentially, but not that terribly difficult to build. And then we have full agent-based models, and we ran both. What I just want to show here is sometimes all the extra effort of making glamorous, really interesting, intricate models really doesn't offer you anything else. I'd go for speed and parsimony any day. So it's easy to fall into a trap, especially when you're learning how to mathematically model things, to like really want to go and do the cool stuff. It's so much fun. But at the end of the day, you spend months and months and months building it, and turns out you have essentially ended up with a program that gives you the same output as 200 rows of code. So it's just something to keep in mind. Okay, so how can mathematical modeling boost the value of PCR tests that we use? So PCR tests and qPCR tests are just like the normal PCR tests we use all the time. And during the pandemic, everyone was using PCR. I'm sure most of you had PCR tests at some point early in the pandemic. But the result, did anyone ever get their CT value back from your PCR test? Did you get yes or no? True, I mean, positive, negative. Yeah, but it's called a quantitative PCR test. It's got numbers, it's got a value. And the PCR actually holds a lot of information, especially when looked at through a lens of population level amount of information. And so quantitative PCR is essentially the cycle threshold. So back in April of 2020, we wrote a note in, I think it was Clinical Infectious Disease, saying, hey, if you really want to leverage the qPCR test and understand your patients, look to the CT value. And the general suggestion was, if somebody's positive, just test them twice. If they have a CT value of like 37 and the next day have a CT value of 38, the higher the CT value, the lower the viral load, then they're probably on their way down. And they probably don't even need to be quarantined, because 37 and 38, that means that you're just not like a bunch of debris left in your nose. But that was not taken very well. People thought that was a horrible idea. It wasn't a horrible idea. Ultimately, most clinicians end up doing that. But the point is, the CT value holds all this information, but it's almost never used. So we started asking questions like, well, if we actually understand how somebody's viral kinetics, on average, how viral kinetics look inside of a person, they go up, like I showed, and then they come down, and they go up exponentially, and they come down slowly. If we understand that, can we layer that on top of what we know about the growth of outbreaks to start understanding something about how the distribution of CT values at any given point in time might actually give us a lot of really rich information about what the outbreak as a whole is doing at that point in time. And this comes from questions like this. Well, you've probably all seen diagrams like this, at least when they're more symmetric, for like age. If you have a rapidly growing population, you're going to see that most people in a population are young. If you have kind of a slowing population in a country, like not a lot of kids, then most people in the population are going to be like middle-aged or older. But when the population is racing northward and you're making babies all over the place, most people, like there's going to be a high distribution of people that are skewed young. The same thing happens with infections. When an infection is racing northward and you have an outbreak that's growing exponentially, most infections that are happening at any given slice in time are new. They're like infections, most people, because they grow exponentially. So at any given point when the virus was going up, you might have 2 people, 4 people, 8 people day to day getting infected. So that means 70–80% of all infections at any given point in time when an outbreak is expanding might have just been exposed within the last 3 or 4 days. So we can leverage that. We can say, okay, well, what does that mean? That means that if most people have been exposed in the last 3 or 4 or 5 days, if we can assume that that's the case when the outbreak is going up, then that should present itself as like the population should have pretty low CT values or pretty high viral loads, because that's when the viral load is highest. On the other hand, if an outbreak is slowing down and you're on the back end of it, most people are going to have had an infection a while ago. There's still going to be some new infections, but in general, the majority of infections, or the majority of the PCR positive cases, will be the tail end of people's infections. Most PCR positive people will have been infected a while back when the outbreak is slowing. So we can leverage that and build models to actually use this data that we otherwise throw away. We literally throw it all away in public health labs. So as I showed before, the viral load within a person changes over orders of magnitude. It goes from 1,000 or 10, to 1 trillion, which is really pretty remarkable, actually. But viral load is kind of thought of as a function of time. There's a lot of other things, immunity and whatnot, but generally speaking, 2, 3, 4 days after exposure, 5 days after exposure, your viral load is peaking. And it's really high. It might be 1 million, it might be 1 trillion, but it's going to be pretty high. And then it's going to come down over the next few weeks, maybe week, maybe 3 weeks. So if we simulate something like this, this is a simulated environment, that's the cases. We have in the blue, that's the daily growth rate. We can look at what do the populations look like. So here we can see if we take a slice right through just about the peak of the outbreak, most of the cases are still red. If each of these is a row is a kid, and the colors, is the person, color is demonstrating the viral load. Red is high viral load, blue is low. Most of the infections, as you take a slice in time here, are in the red. And you have a few blue that are right at the beginning and then a bunch of blue that are at the end. But if you come over here, you start to see that change pretty dramatically. That's slicing through a lot of blue and not a lot of red. And that's because it's later on at the tail end of the pandemic. So what that means is we're actually getting, you can see that in days since infection, or maybe the most objective value we have is the distribution of CT values. So at the beginning phases of an outbreak, you might not have as many cases because the outbreak is just getting going. But if you don't have a lot of cases, but you see this really almost uniform to a degree distribution of CT values, then that means there's a lot of people actually with pretty high CT values relative to what it should be. So asymmetric. As you go further and further down, you start to see the CT values start to concentrate much more in like the 30 to 40 range, really low viral loads. So if you see a distribution that looks like that, much more of a teardrop shape, you're probably towards the end of an outbreak. So we can take this kind of information, we can actually say, well, can we use this in real life? Based on what we know about the viral trajectory, the CT values over time of an infection for an individual, with a lot of variance at the population level when we model it, can we actually understand and look at the distribution of CT values like I have on the bottom there, and answer the question, does it predict where we are in an outbreak? And it actually does. So this is Massachusetts. These are real CT values from Massachusetts, starting in April of 2020, going up to November of 2020. And you can see this marked change in the distribution of CT values. So at the beginning, you have a pretty uniform distribution of CT values, but when the outbreak, and that's right here when the outbreak is going up and at its peak, as cases came way down, you start to see that distribution of each of the CT values falls. And then you see it start to pick up again as soon as the growth rate starts to pick up. And so we can actually take these distributions and start modeling out the growth rate, the expected growth rate at any given cross section of time. And we can say, okay, here the growth rate is positive, negative, a little bit negative, positive, negative, positive. So we can take that thinking and actually build more of a framework around it to understand what that all means. And from that, I won't go into detail about how we did it, but if we look at a simulated outbreak right here, we have, this is the incidence in the red line, and the orange is the prevalence of PCR positivity. So we're actually measuring the prevalence, not the incidence, because we're measuring everyone who's PCR positive in the community at a given time that we're testing. And with just 50 samples, you don't need a lot. Normally, if we're trying to figure out, is the outbreak expanding, is it going down? Normally, I didn't really give enough background here, you have to have cases, you have to have tons of cases, and you're monitoring cases daily. You know, everyone probably looked at things like the New York Times website for all the case counts. That's how we normally know if cases are going up or going down, is just like literally looking at case counts. But that's fraught with so many biases. Who's getting tested? Why are they getting tested? Was there a new mega lab that just opened that's driving a lot more cases? And so it's hard to break through that noise. But CT values and a distribution across the population don't really lie. And so if we take 50 samples from different parts of the outbreak, if we take from, for example, when the outbreak is just going up, this is what in this particular simulation, this is the number, this is the CT values, and this is sort of the histogram of what those CT values look like. It's a little bit kind of uniform, not really uniform, but not really bell-shaped either. But then if you do the same thing all the way down here, the distribution is markedly different. Almost all of the positive results are between 30 and 40. And so it turns out we can do a bunch of mathematical models, this is all Bayesian modeling, and we can actually look and get a pretty darn good estimate from just these cross-sectional CT values alone. We were able to reconstruct where this outbreak is. And this is the ground truth, this red line right here. So we're actually able to reconstruct exactly sort of what's happening. Because at any given normally behaved outbreak, you should really only have a given distribution of CT values for any place along that outbreak. So it shows us that we actually can take these CT values and back calculate back into where exactly the outbreak is by thinking about the internal kinetics of what's happening at the individual level and mapping that onto the population. We can then answer questions like, well, all the biases that happen when cases are going up, and you don't know, like, is incidence really going up, or is our testing capacity going up? That was a big, big question. It's like kind of irrelevant now, sort of, but it's not. It's still a really important question. But it was something that people like me thought about anyway. And Trump talked about it a lot. And it's just how it was. But so one of the questions is, well, if testing is falling down, then the New York Times data would look like cases were falling down. But what if cases weren't falling down? What if they were flat or going up and just testing was dropping off? It would look in our data like it was falling down, but not with CT values. This is what, if testing was declining, it would look like the growth rate was going down here. But when we use our CT value approach, we get real, like very good stability across the board in terms of our estimates of growth rate. This is the ground truth. And this is what we get across our simulations in all different scenarios of like increasing testing, decreasing testing. And so the point of this is to suggest that these tools can be remarkably well used when allowed to. And the CT value, really understanding the kinetics of a virus at the internal level, in terms of how it's growing in the body and what those distributions look like, can have a lot of power when we start to think about what happens at the population level and how can we use something as simple as a PCR test. So this is that same Massachusetts data. This is what relative probability of infection looks like. When we took the CT values, we can actually get at incidence, and we can actually back calculate across the epidemic. What did the incidence generally look like across, in this case, Massachusetts? And we can even just look at something as simple as the median of the CTs against the skewness of the CT distribution, so that the shape of those distributions. And we can actually, from that alone, we can map on RT for the most part, which is pretty interesting, that just the shape of the distribution has enormous information. And this is just one video example of what this looks like when we added and actually ran these algorithms with against CT values. In the red is actually the true incidence in the simulation. And this is the incidence that's calculated purely from CT value distributions as we added more and more and more distributions. So it really offers pretty interesting tools, in my opinion. Now let's see how I go for it. Okay, what time is it? Does anyone have a time? Does this end up in like 8 minutes? Yeah, okay. So I wanted to talk a little bit about this other completely different effort, which I think is pretty interesting. And it's how can we monitor outbreaks using antibodies? And then where does like AI and mathematics come into this? So I won't go through the difference between viral infections and antibody measurements, but antibodies are really useful. Like using something like PCR antigen tests is good to know the here and now. But where antibody testing and serology come in is to understand where might an outbreak be going. You can get at voids of infection. Where are there gaps in immunity at a population level? Where is there a lot of immunity? Where are new infections happening? So I like to think of PCR as kind of like the here and now, and antibody testing at scale can really become almost like a weather system. You can start to predict the future with it. I'll skip a few of these, but this is from another agent-based model. But the question was, well, antibodies are delayed. They take around like 6, 7, 8 days to return results. I mean, to expand up so that they can be detectable during a new infection. So why would we ever do it instead of PCR? And that's kind of the message that was sent around throughout the whole pandemic. We're going to go with PCR, not antibody testing, because antibody testing is delayed. But at a population level, that delay becomes kind of insignificant. 10 days delayed on any given individual is insignificant if you can increase the scale of your surveillance program. So the y-axis here is how many days into an outbreak did it take to detect an outbreak? The blue is antibody testing, the orange is viral testing with rapid antigen tests. And these are different situations of like how frequently you're doing the testing and on what fraction of the population. And what I want to show is, first of all, these would be like enormous amounts of testing. These are already way beyond what we would normally do. But if we're using serology, we can actually do that in the background. Every time you bring a blood sample to a clinician, or every time you draw blood for any reason, there's an ability to potentially take a discarded specimen and run it for serological purposes. And so it turns out that when you look at it from a population perspective, serology is just as fast, if not faster. And when you consider the scale at which you can do serology, it's going to detect outbreaks much more effectively and efficiently than a PCR test would over what's actually practical in real life settings. Normally, serological assays look at like one test, a COVID antibody test or a flu antibody test or RSV. But new approaches allow us to test hundreds of thousands of different antibodies at once. And so I won't go too much in detail about how, but essentially we use a synthetic biology approach. We package oligos, we download the proteomes of all human pathogens, we carve them up computationally, we package them into a data file, get those oligos printed on DNA microarrays from a company, and then we package them into phage. Once they're in a phage form, then they persist. You only have to do that other step once. And then you can keep creating phage. And each clone of the phage almost acts as like a little mini ELISA, but hundreds of thousands of mini ELISAs inside a well. And so what you can do, each column, this is just an example of what the data looks like. Each column is a person and each row is a different protein from a different pathogen. I'm just showing 4 pathogens here, but we've got 400 of them in the library. And you could take less than a drop of blood and you can get an entire array of antibodies for a given individual. So you see there are some antibodies that most people have. These are the more public ones. But then on any column, you see that each column is a little unique. It turns out we all have encoded barcodes into us based around our immune repertoire. And so we can look at that, and this is the kind of data we have. So each one of those little red lines is essentially an antibody titer for an antibody hitting a specific target of a pathogen. We could look at that and we could follow kids longitudinally. For example, here you can see rubella virus antibodies. See, this is a birth cohort, age of days in life. So you can see maternal antibodies waning, and then you can see they get a vaccine. So we could use this, for example, to look at rubella. It's not very interesting. ELISAs would probably do a better job at one virus per one virus. But you don't just get rubella, you get measles virus antibodies too. And you don't just get rubella and measles viruses, you actually get antibody titers to all of the viruses that we know infect humans. We can also include things like the human proteome into this to look at autoantibodies and correlations between autoantibodies and antibodies that hit viruses. So this is just a big step change in terms of the type of assays we can build. The whole process of doing this can cost less than $20 per sample, and I believe it can get sub 10 over time, which is about the price that we pay for a single antibody. We get instead 200,000 antibody measurements. So it really changes the thinking of what we can do with this kind of data. This is one of the more interesting pieces of data. I just love this. So all of this data comes from one person, and that other red graph I showed, it might look like that's a lot of noise, like maybe it's not a very specific assay. Each column look different, but like, is that just noise? But this is just an example of one person and taken over 10 years of time. So from left to right in each of these is about a 10-year time span. And it's the same person, I just carved it up so you can see it through different pathogens. What you can see is there's remarkable stability, almost to the point where like this person, the sampling over 10 years of time created effectively a barcode for this person. But you can see the barcode changes every once in a while. They got a flu A infection here. They got a flu B infection here. They had an EBV activation over there. So there's definitely changes that happen. But in general, we have like a pretty immutable barcode that could actually be used to start linking samples together to help build out cohorts of individuals from blood donors, for example. You don't necessarily need their identity. You could actually say, hey, I have no idea who this blood is from, but these two samples came from the same person. And in between the two donations, we saw that there was actually a new antibody form like flu A. So we know from that one pair that there was a flu A infection somewhere. And if you do that enough people, you start to get at the front edge of outbreaks. and not just flu or COVID, but anything. We can start actually understanding the endemic dynamics of every pathogen that infect us. This is an example of the type of correlation we see. So if we have just like a mishmash of different donors with different antibody targets, we can actually use the correlation within somebody's own antibody repertoire to start to link their samples together over years and say, hey, actually, all of these were from the same person. All these were from the same person. And you can start to tether longitudinal cohorts together without actually prospectively spending the money and time to like go to each of their house, repeatedly every 6 months, because it's very expensive. So almost overnight, if you work with a big blood bank, we had probably the largest longitudinal cohort ever created for immunological measurements. And that's because we partnered with a large blood collection company in the US to do some of this work. And we didn't have to actually go out of our way to go find those people and repeatedly collect from them. We were able to search through our databases and say, this blood sample from January is from the same person that this blood sample came from March. We don't know who they are. We did know what zip code they lived in. And so this is an example of what that looks like. I just kind of talked about that, but effectively you just see within the same donor, you see very, very high correlation. We've done this many times. We've searched through tens of thousands of samples, and our accuracy is on par with genomics. We don't get any false matches that aren't actually from the same individual. So this is where some of the AI stuff comes in. So there's some really interesting applications that could be had for like measuring antibody repertoires at scale and being able to link them. You could really start to do sort of monitoring of pathogens at scale and understand the rules of the road for how viruses transmit based on looking through the lens of the immune signature. But also, what about novel pathogens? Well, it turns out that our immune system detects novel pathogens, unsurprisingly, a little bit different than it detects other pathogens. So when Zika hit, 2016 or 15, when we already had dengue plugged into this library, because dengue virus was already in the library as one of the viruses we knew about. We didn't yet have Zika plugged in because it's a novel virus that we didn't think about. But what we did was we said, well, let's just get some Zika samples and see what it looks like when we look at the antibody response in the Zika infected people, but against dengue virus. There's a lot of cross-reactivity, it turns out. But that cross-reactivity was like hard to make sense of initially. There was no clear pattern of what the difference between Zika and dengue was. But then we can actually take it, we can do all kinds of mutagenesis studies to really understand the exact amino acid where antibodies bind. And we can then take all of this information, which is just a huge amount of antibody information, against the dengue genome, but looking at both dengue-infected people and Zika-infected people. And we can ultimately run, in this case, we were running both support vector machines and CNNs, and then we ultimately created a number of different models, but we ended up with an ensemble approach of models. And with only 20 or so Zika-infected individuals and 20 and so dengue-infected individuals, we came up with an out-of-sample, 100% accurate model for distinguishing and identifying Zika-infected individuals. This is without changing the model, the base assay at all. So why is this important? It's important because the majority of the companies spent about a year after Zika was discovered to develop a good discriminatory assay. We have one sitting under our nose without ever having to change or build anything biologically new. And that's because we had so much data about the intricacies of how the antibodies bind and what's normal and expected for dengue, that when we had a lot of that same normal-ish stuff with Zika, there was enough different that our CNNs were able to pick it up pretty darn easily. And so if we do this at scale across the whole of the continent or the US, whatever it might be, leveraging things like government health programs, blood donor sites, any way that you want to get discarded blood from people, you can start thinking, wow, we have a tool now that not only allows us to map pathogens and what they're doing and where they're going, but also be very quick to identify new pathogens. Once we know what normal looks like, if COVID was spread, if we were running this in 2019, we absolutely would have known what normal beta coronavirus immune responses look like. And before the first PCR test was ever run on anyone in the US, if we were screening the US blood bank with these kinds of tools, we would have picked up SARS-CoV-2. We would have been able to say, hey, there's a new coronavirus. We don't know what it is, but then you look in the media and you see that there's something new circulating in China, and we would have picked it up before any PCR test was ever run with the intention of looking for COVID. So that's where I believe that these tools can lead to something like a global surveillance program and immune observatory. That's something that we've been working on for a long time. It works with saliva as well as blood. So when you rub your gums with just like a sponge, that's just like a little bit abrasive, but still soft, you have all these microcapillaries. And so you have lots of IgG that actually exudes from your gums. And so you can pretty much get this serological assay just from rubbing a sponge on your gums and putting it in buffer instead of collecting blood. So I won't go into all the other ways, but measuring the immune repertoire has like so many other utilities. We've discovered all kinds of things with it, autoimmune disease, cancer, all kinds of things. When you're starting to look through the lens of a large immune repertoire, it drives home a lot of understanding both about pathogen dynamics, but pathogenesis of infections, cancer, autoimmunity. So I'll leave it with this, that maybe one day we would end up having something like a biorepository where you have global collections. Each country has their own repository of specimens that can be processed on assays like this one, that we can actually get countries around the world to be able to process. The nice thing about antibody responses is they're totally anonymous. So you can upload them without concern about any sort of information about a specific individual, as long as you don't share who they are at one point in time. But you can have data and statistics modeling courses that are really driving a lot of the mathematical underpinnings of how to make sense of all this data. You can have biobanks that ultimately go to other immunological cores that can look at samples more deeply. If you find something like, hey, we just found this really interesting antibody that might be a neutralizing antibody for some new pathogen, maybe we can go back to that person somehow or to their initial blood sample and look at their B cells and sequence the result, or sequence the antibody directly with some new protein sequencing tools to get at what might be a fully new neutralizing pharmaceutical for some novel drug. There's lots of different ways that this can be used beyond just surveillance, but it's getting there. It's having to find government funding that's actually interested in this kind of work is certainly a long road. We've been working on for about 10 years. And it's COVID actually made things much worse. There was at least interest in serosurveillance before, and then COVID made everyone think that serosurveillance was like magic or fake magic or something like that. So there was a complete loss of interest in it. And now it's building up again with H5 and Mpox. And people are saying, well, shoot, we should be doing serosurveillance for Mpox. Well, yeah, of course. So, anyway, I'll stop there. I went a little long.
That was great. So while you guys are thinking about questions, I'm going to start with one from online.
Sure.
So this is from Alin Morariu. Question is, how early during a pandemic do we actually have information about viral load curves from an emerging virus? So, the data that you looked at, I guess, was retrospective. You're doing an analysis. So how quickly can we get this kind of analysis in real time?
Yeah, so that was something that actually when we first built those models, which turned out to be extraordinarily close to what ended up being measured, we didn't actually have any empirical data on exactly what the viral load curves look like. What we did have is a lot of data on beta coronaviruses and other viruses, and we had a lot of epi data around certain kinetics and when peak viral load was relative to symptoms. And so we were able to take a whole bunch of different disparate data sets. You don't actually need to just collect, within an individual daily viral loads. You can do that. That's the gold standard, I suppose. But there's a tremendous number of ways to use epi data coupled with CT viral load data at the population level to start constructing what you expect based on prior knowledge of viral infections, what those viral load curves will look like. And that was actually a big question we got when we went to publish initially was, they said, well, where is the data for exactly what these viral load curves look like? We said, well, this is how the virus works. This is the molecular aspects of it. We know what it looks like, and it all matches the epi data. We know when transmission happens relative to symptom onset. But there were still questions Nevertheless, ultimately, we were able to show that it did exist, but getting that actual data took a long time. You have to set up prospective individual collections on a daily basis and get people early. But you don't actually have to do it, which it's a really good question because like for this group, you can couple mathematics and prior knowledge to like reconstruct it way before you actually get the ground truth. I would say, and that's exactly what we did. It's not if it was HIV, that might be a little different because we have really no ground truth on, or no priors on really what HIV replication would necessarily look like. But this wasn't HIV. This is a very normal behaved virus, data coronavirus.
Thank you for the talk. It was very interesting. So, for the first part, I really love the topic. I love the science. I love the mathematical model. I love the simulation. I love everything about it. But looking back in retrospect, it will have been very great. But how do we manage the emotions of both the researchers, scientists, the policymakers to actually accept such a wonderful thing that thought?
Well, don't ask my wife that. It was honestly harder than I could describe publicly. The thing, like when you start talking about things like this, that in retrospect seems so darn simple, right? It's like, okay, yeah, the virus load goes up, the virus load goes down. You want to catch that window. If you're testing back 7 days later, that's bad. It's not hard, but it was remarkably hard. I wrote an article in the New York Times in May or June of 2020. And before that, I wrote that article I mentioned in CID talking about what's the CT thresholds and CT values to start understanding this COVID test. And it was hit with amazing amounts of pushback from the pathologists, from clinicians, and even from public health people. Like really, it was either love, but it was mostly like those ideas about, hey, every American should have rapid tests so we can help curb spread so the average person can play their role in this pandemic and not spread to their neighbors or their loved ones. That resonated with most like normal people. It was like, the idea was like splashed as like main pages in the Atlantic and the Times, all over the place, CNN. But most physicians and clinicians and regulatory people hated it because it broke dogma. And so it's one of the best questions you can ask, like, how do you do it? I made a decision early in the pandemic for myself. I hate testing. Like, I do not like talking about testing. I like immunology and vaccines and stuff. That's what I love. But I made a decision early that if I was going to have an impact, I was just going to stick with it. Now people think I'm like crazy because I talk about rapid tests a lot. But it was because, like, it was as simple as it was so far out there. People really hated the idea. They couldn't stand the idea of a test that wasn't as sensitive as PCR. It made people scared. It made them feel like they weren't doing the right thing for their patient. So many emotions, you use the right word. There's so many emotions wrapped up, and I don't have a good answer. I just made a deal with myself. I put a Post-it note on my computer, and I said, every time I'm on with the media from CNN or whatever, I'm going to say that testing needs to be fast, accessible, and affordable. And like I said that all the time, and slowly did start to make a difference. I started talking to the White House, started talking to the FDA a lot, but it was an enormous effort, and I got a lot of like hate now from our colleagues, literally. And so I don't have a good answer. To me, I felt like I actually had to like be an advocate, and I'm not usually an advocate. I don't know. It was challenging, but one of the best things was, and one of the most important things for me was there was this whole community of people that literally rose up out of like the internet. I don't know how. They created like Slack channels, invited me. They created like rapidtest.org. We wrote, and they asked me just to like lead all these efforts. Like, okay, I don't know who all of you are, but it was very, very important. Like, usually you hear people say, "Oh, write to your congressperson about this and that." Nothing. But it actually did. We wrote letters to Congress people. I got in front of Congress and talked about it. There was this whole groundswell of support to help me do that. Lawyers, all these people who just like this one billionaire gave me the vice president of his company because she was out on maternity leave and didn't have anything to go back to when she came back from work. It's a pandemic. He said, why doesn't she work for you? She's really good with government stuff. And for free. And so she did. And it was just like this amazing effort. It was truly like this like groundswell of people not supporting me, just supporting everyone getting access to testing in the middle of a horrible pandemic when the government couldn't see clearly. So it was like that. I don't know. It's really, really hard. But it was also science. It was published. I mean, it's ridiculous to think about getting a New England Journal piece in just saying that, like, you have to test frequently to catch a virus that's transient. But, you know, it took just going back to the basics.
Hi, Dr. Mina. My name is Robin. I really like the talk. I remember you have shown that the more frequent you test, the rapid test, the fewer people you will infect on a daily basis. So I wonder, in the next outbreak, how to ensure that people take tests daily, and will lockdown still happen?
Well, I don't think you can ever ensure that people are going to take tests daily. But what I can say is if the question is take a test daily or every 3 days or be locked down, I think people would rather take a test that takes 5 minutes or you know, once you learn how to use these, it takes 20 seconds of hands-on time once you learn how to use it. And it doesn't need to be perfect. People say, but some people might not do it or some people will lie. You know what? That's part of it. Like, it's okay. It's not okay, but it is okay. Like, from a population perspective, you're just trying to get R below 1 and keep the outbreaks from bursting forward. And most people, I believe, are good people. They don't want to go get their mom sick or their church people sick or their coworkers sick. Some people might. And, you know, it's like that or nothing, or lockdowns. And so I think, to me, the way that we answer your question is we let people. We don't try to create top-down approaches of the government locking you down or this or that. The thing that resonates with me personally, and that resonated for a lot of Americans anyway, and globally, people all over the globe, was that a rapid test is an embodiment of having some control over your destiny, you know, having some control over your piece of this otherwise extremely scary thing that was happening in the world. That's invisible, and having a test that allows you to see something and feel empowered by it was incredibly empowering for lots and lots of people. And if you look in the United States, there was this big divide. You know, you had people who didn't want to wear masks. You had people who didn't want to do this or that, didn't want to get vaccinated, did want it, all different things. The cool thing about a rapid test, didn't want to report a results. Well, it's a rapid test. You can report it if you want to report it. If you don't want to admit to anyone in your hometown in your Midwest America that you know, are concerned about COVID because there's a stigma around being concerned about COVID, you can do your test in the privacy of your bathroom. Then your nearest family members don't need to know about it. And if you're positive, then you figure out what to do. So I've always loved that it was very much a bipartisan issue. It was very much something that everyone could get behind because it was about the individual. It wasn't about some other person. And I think that more so than almost anything else, including masks. It's like people might notice that I never talked about masks online on Twitter and stuff. It wasn't because I don't use masks, it wasn't because I don't like masks, but I think a rapid test, like if you're going to a conference, rapid test is something you can do in private. And if you have everyone using rapid test right beforehand, the positives will ideally not go in. And then you have effectively a mostly sterile, if you will, like environment. There might still be some cases, but with masks, for example, A, it's visible. It's going to, some people won't feel comfortable for lots of different reasons in society to do it. It's uncomfortable. You always have to take it off because you have to drink and eat. So it's not even that useful at the end of the day in that kind of setting. And so I've just always gravitated more to what can the average person do on their own, and believe that during crises like this, people will take the initiative. And if they don't, they don't. That's our society. Like, we all have to live in it. But I don't think a top-down approach works either. I do believe firmly that the very stringent things we did, like lockdowns, while essential, I think if we don't learn from it, we're really screwing ourselves over because we're already seeing the downfall of those pretty draconian measures, which again, I think were right at the time. But we should learn and realize that they're actually hurting us in the long run.
Thank you.
In your immune surveillance model, are you able to differentiate between vaccine-mediated immunity and the old wild type?
Absolutely.
And does that help you in because I think of the, like right now, we're seeing upticks of measles, we're seeing upticks of pertussis. And a lot of people, I think reasonably are saying, yeah, we had this vaccine oasis during the pandemic and we haven't caught up, so we've got way more susceptibles. It seems to me that if you can monitor also vaccine mediated, then you'd be able to monitor that along the way too, yes?
Absolutely. And that's what the nice thing about, like, when I didn't go too much into the technology, but we literally take the entire genome. So if it's a vaccine like coronavirus, you can actually get very specific targets that might be on a vaccine. You know, if it's just vaccine versus corona, and it's completely wild type spike protein, for example, in somebody who at the same time got an infection, that would be hard to disentangle, but you probably see an excess of antibodies against the spike, for example, compared to a baseline of antibodies against the rest of the virus that even in a pretty difficult scenario would help you understand that. Measles, though, we've looked at it. Measles is very tricky because the whole live virus. But even that, we're starting to get signatures of where we can identify differences. One thing that I want to do, which is a little bit controversial, is like, why don't we put epitope targets, synthetic targets into our vaccines so that we always have like a little immune signature, like doesn't need no, and I say this like we get exposed to a million different things in life. Like, what is one more? We make sure that it's like every time we touch dirt, we're getting epitope targets, you know, that we're ingesting. And what if we took one of those that we know is very safe? Maybe in America, it's like something that people in Asia get exposed to all the time. We know it's like healthy for, you know, it's just fine. It's just another thing that we develop so many antibodies. My thinking is just, are there targets we can put into a vaccine to help us distinguish that? Maybe not. Maybe it's not a good idea, but I think it's interesting to ponder.
I think you play naturally into the, what people maintain is disinformation about the COVID vaccines were really just tagging each of us or chipping each of us. I think what you just described would play nicely into that.
Oh, I'm sure it would. And that's where, you know, it takes education, and if society doesn't want to get behind it, then we don't do it. I feel very strongly about that too. But it's just an idea. There's not a lot of ways for some of these, but certainly just taking the vaccines that we have. Like, for example, if we had a vaccine, lots of vaccines are built on backbones that aren't the natural infection. What if that backbone is just something, if it's something we don't normally get infected with, then that's already a tag. And we just don't call it that. And so there's a lot of epitopes already in vaccines that like don't exist anymore in the natural environment. So we could pour through the vaccine, you know, the actual comparisons and try to find those, you know, systematically. I bet I would be surprised if there's not a few epitopes in every single vaccine that are novel to the vaccine and serve as that tag that I was just referring to without us actually intentionally.
I think your allusion to social consensus is an interesting one all on its own. I don't know what it's like in the US, but in Canada, we seem to be becoming a little more polarized. Maybe you're a more consensus-based country.
Oh, definitely.
So I guess on that note of future pandemics and rapid tests. So if I remember correctly, we only had those rapid tests well until maybe 2021. So maybe for the first year, for the beginning of pandemics, really the only thing we have to know if someone is infected is through a PCR test that, like you said, would take a relatively long time to do. So I guess based on your models and other stuff like that, do you have, I guess, any suggestions for future us if we ever see a pandemic again? We're still in the early phase of developing new rapid tests to catch those diseases.
Yeah, so two parts of that. The first time I ever held a COVID rapid test was April of 2020. And so rapid tests they've been around forever, like for malaria, dengue, they cost not the $30 that they were sold from the US. They cost about 50, 40 cents to make. They're much cheaper than pretty much anything else we could build. And we know how to build them really fast. It was all the regulatory battles that I was talking about before with physicians. People hated the idea. There in the US anyway, there's also, well, I won't get into the corruption part of it. There were lots of problems. But let's say we didn't know, like, let's say it wasn't that easy to build and it's not a technology we count on. And for certain viruses and pathogens, it might not be. Like the viral load doesn't get high enough for a specimen type, but it is high enough to transmit. Then we couldn't count on it. Maybe you couldn't PCR. So one of the ways that we're dealing with it is to have an action network set up specifically, not like underfunded public health labs. Like I've looked at this, for example, we have a DoD budget in the US. Like, why doesn't the Department of Defense just have like warehouses, 8 mega warehouses in the US of Roche 8800 lines, which can each run, massive numbers of PCR tests every day? We should just keep that at the ready because PCR is easy to, get us an assay started. Why are we counting on all these other, either public health labs that are chronically underfunded and cannot do it? Or in the pandemic, we had a lot of pop-up labs start. We had to go, like, I couldn't even get my hospital to believe COVID was going to be a thing when I was the head of molecular biology at the time at Harvard Hospital. And I got laughed out of the room in January when I tried to create a COVID test. They said, no, go back, we're not going to give you the resources. So it's not just the technology, it's the barriers of people getting the right information. And if the government did lead these things, and if we saw certain governments like South Korea did an amazing job at getting Singapore did an amazing job. These were countries that could coalesce resources very quickly. US couldn't. We have a very fragmented, kind of like Canada, you have fewer fragments, but you have your provinces and we have our states. 50 is really hard to manage, and each state had to go and do its own thing. Each lab had to get its own certification. So why not just have it would be relatively very, very cheap to have warehouses underground that just have, like, if you've ever seen a clinical pathology lab, it's all automated, it's all robots. You could run hundreds of thousands through a warehouse in a day, no problem, without really any. I mean, you'd have to keep a little bit of upkeep, but so put the National Guard on there, whoever, just to maintain it. It would be extremely cheap to do relative to what other things we are doing. And that's one thing that I would want to see is just have the logistics set up ahead of time, have the laboratories set up. Don't make them privately funded laboratories because they're always going to get distracted by where the money is, where they go out of business. So they can't make it through the gaps. It's got to be a government funded thing, or government has to fund things like a loan base, which CDC is now starting to do with a number of labs. But I think that runs risks too, because the warm-based labs that they're selecting, like LabCorp and Quest, and they have their clinical responsibilities. So all of a sudden they have to run